which is probably an appropriate moment at which to turn to Ian's paper on the multi-specialty community programme and invite you to speak to that, Ian.
Thank you very much, Malcolm. It's almost exactly a year ago today that the board discussed and agreed the national support package for the new care models programme. Since then, the vanguards have been getting on with making change happen. And so the snappily titled Multi-Specialty Community Provider Emerging Care Model and Contract Framework, which I have here, isn't just a theoretical policy document. It's assembled from what the 14 different MCP communities are actually doing. And today we are defining what it means to be an MCP, and we're setting out the different options for commissioning and contracting. And so it's a significant moment, I think, in the new care model programme and indeed the implementation of the forward view. I will highlight 5 main points. First, the connection with sustainability and transformation plans. Most of the 44 place centre stage new models of accountable care provision, whether this is in the form of an MCP or the wider PACS model that also includes all the hospital services. And so it's clear that the NHS sees MCPs as an essential transmission mechanism to help turn STPs into reality. Secondly, picking up on the conversation we've just had about developing and sustaining general practice, MCPs, I think, have a critical role in this in 4 ways. So the first is supporting general practice at scale, including the development of emerging GP federations. Secondly, through the additional benefits of combining with wider community teams. Thirdly, in creating new career options for clinicians as part of these bigger integrated entities. And fourthly, through the additional oomph that the MCP can provide in activating and working with communities and patients to help tackle demand within general practice itself. Thirdly, I'll very briefly outline the core care model. An MCP is what it says it is. It's multi-specialty, the point that Jane's just made. It's not just about a particular set of clinicians. It's community-based, and it's a provider rather than a new form of commissioning. It holds and then flexibly deploys a whole population budget. It depends on achieving a deep understanding of its population's needs, drawing on interoperable records and world-class business intelligence. It focuses on prevention across the whole population. It redesigns urgent care as part of a streamlined urgent and emergency care system. It integrates primary and community services in hubs, typically of the 30 to 50,000 population size. Arvin mentioned the primary care homework that NAPC is doing on developing exactly that model. And it also provides intensive proactive care for small cohorts of patients with the very highest needs. And in the framework, we highlight examples of what that means in practice, whether community volunteering in Sunderland, the extensivist model in Fylde Coast, near Blackpool, outpatients redesign in Stockport and Tower Hamlets, urgent care redesign in Rushcliffe in Nottingham. Fourthly, I turn to commissioning and contracting. By far the most important job for an MCP is the care redesign rather than just financial rewiring. We're really clear you can't just procure an MCP into being. It requires very significant change management, engagement and development of the workforce and care pathways over multiple years. But ultimately, for all MCPs and indeed new care models to be sustainable, they need to be commissioned so that the financial flows and organisational governance arrangements actively help rather than hinder staff to do the right thing. And so working intensively with 6 local systems and national stakeholders and partners such as NHS Improvement, we've been developing 3 core approaches to contracting for an MCP. First, alliancing arrangements. Secondly, a partially integrated MCP contract. And third, a fully integrated MCP contract. And in the framework, we then describe the core design principles underpinning these, the new budgetary arrangements, including a whole population budget, new pay-for-performance arrangements that synthesize and redevelop QOF and Sequin, the different options for organisational form, the different ways of securing the relationship with GPs, and the procurement method. And we will be publishing a first draft, full draft of the MCP contract in September. My final point is on wider spread. At the moment, 8% of the country is currently covered by a nationally supported MCP or PACS Vanguard. We expect that this may expand up to around 25% from 2017-18, supported through a dedicated new care models funding stream which is linked to the STP process. So I conclude by commending, I think, the fantastic pioneering work of the MCP Vanguards and by inviting the board to endorse the model.
Thank you very much, Ian. Let me invite the board to raise any comments on the paper. Yes, please, Noel.
Ian, I think this is a tremendous work you've done on the design. It's comprehensive, it's holistic. And in terms of what patients will see as the benefits from the rollout of MCP over time, I sense that the pace at which you're going to get to a quarter of the country is indeed quite accelerated. But what I'm interested in is how we're putting in place some measures around what outcomes patients will see from the rollout of MCPs more widely, and whether you think we need new ways of assessing impact and assessing outcome and assessing measures, which will be another layer of the design if we are indeed to measure the benefits that patients see from MCPs compared to the information that we get today.
Thank you, Noel. MCPs and PACS as whole population models are integrative devices. They're about progressing all three parts of the triple aim: better health and well-being, better quality care, and financial sustainability. And so the national evaluation metric set covers all three of those aspects. Equally, all of the MCPs and PACS separately have their own local core metrics that they're going after, and they're supported typically by £200,000 worth of national funding with local evaluation work. Across those three domains, we have a clear new indicator set for local communities in the form of the CCG Improvement and Assessment Framework. And that sets out a range of different metrics which STPs have been using to look at what the current starting point is in their local population and where they want to improve. And that is feeding through into the work that the MCPs and PACS are progressing, specifically on financial sustainability and the contribution that the MCPs and PACS will make to delivering the efficiency savings. There are two different aspects that all of the care models are looking at. One is the demand moderation elements, and that is manifests itself in reductions in avoidable emergency admissions, but also, in the example of Foul Coast, for example, A&E attendances and outpatient appointments, as well as elective care. And then the second is in relation to provider efficiencies as a result of the synergies you can get from creating new integrated multidisciplinary teams. So there's a pretty comprehensive metric set that deals with both the whole population perspective, the patient perspective, and indeed the taxpayer perspective.
Victor.
Just following on from Noel's question, I'm curious about, when people talk about patients and citizens, I'm curious about which patients and which citizens, and in that regard, I wouldn't mind knowing a bit more about how this particular model will impact on inequalities, mental health, which is an issue that we've raised, and the promotion of social care integration.
Thank you, Victor. So I think there's some really great examples in terms of the design and the initial adoption in relation to each of those areas. However, there is also more work to be done within the vanguards as they move from their current plans towards achieving full maturity in each of those different elements. I'll just touch briefly on the design potential and then some of the current examples we're seeing. So, one of the purposes of creating a whole population budget that combines existing primary medical services spend, community services spend, and some of these other budgets into a larger and more resilient provider entity is it creates the opportunity to redesign care services around what are genuinely the different needs of different populations. So if you look at what, for example, the South Somerset PACS has been doing, they identify that something like 50% of their spend is on 4% of their patients. If you have a single bigger budget for all of those out-of-hospital services, they're able to target and deploy that budget far more effectively at basically intensive services on the patients that have the very highest need, and indeed looking at particular communities and neighbourhoods within their geography where the services currently atomised are unable to provide the kind of high-dose intervention that we would all look to try and see. And we've got some really good examples where vanguards are specifically tackling inequalities. We're working with the Institute of Health Equity and Sir Michael Marmot in 2 MCPs in Cheshire West and in Tower Hamlets to be able to improve the granularity of the data set of how they tackle inequalities and what they do by way of their impact. I think all of them, all of the MCPs I've seen, and I've read all of their value propositions and visited many of them, have built into their model tackling inequalities at their core. Have they all made substantial progress around that yet? Some, but there is more work to do. On mental health, we are similarly seeing the vanguards integrate physical health in the community with mental health in the community. This is, I think, an increasing journey. We had a few, such as in Hampshire, the work that the GPs in Gosport and Fareham, connecting with Southern Healthcare, have been doing around creating integrated teams that include mental health for the first time. And as most of our MCPs have been going through their journey of understanding their population needs, they're increasingly looking to provide that integration. I was up in Birmingham on Friday talking to some of the people in Dudley and indeed in the Merit wider mental health vanguard. And if you look at the service specification, the prospectus that Dudley have produced, they have over the last 6 months decided to include mental health as a core part of what they're doing. We can see a similar journey in relation to social care integration, and the framework highlights in particular the excellent work that Sunderland are doing around reablement services. So I think there's lots of green shoots. This is built into the design, but much more to do around systematic execution.
Thanks, Ian.
John. Ian, this is a pretty elegant piece of work, and I'm very impressed by it. I'm just thinking about how GPs will react to it. In particular, Arvin was encouraging us that we've got to see an upsurge in recruitment to general practice, but my colleagues in general practice tell me there's a sort of generational shift away from being partners towards contractual GPs. What's your feel for the different generations of GPs' reaction to this? One senses perhaps this could be seen as a very positive move for those younger GPs who don't want to be partners in small practices but would rather be part of a bigger organisation. Is that your take as well?
The point I'd emphasise above all others is that we've developed this as a voluntary set of options for GPs. We've said if practices want to continue to work as they currently are, whether this is individual, small partnerships, or salary GPs in their current practices, then that's fine, that's great. But what we are trying to do is going with the grain of what the profession itself has wanted over multiple years. And I personally have spent a chunk of the last 20 years of working in the NHS in engaging with general practice and GP leaders around their aspirations for creating a more sensible set of provision, a fatter version of general practice in terms of the scope of services. For decades, the aspirations of the profession have been to join up more effectively their practice nurses with community matrons, with district nurses, with domiciliary care nurses, in order that they can redesign care around what patients need and what makes most sense professionally, rather than the legacy different institutions. And so what we're doing here is we're trying to create a set of different voluntary options for clinicians to work together in a way that is institutionally blind, and we're seeing in our areas a huge groundswell of interest in doing that because it's based on their professional values. Now within that, inevitably, if people are content with their current arrangements, then we need to make sure that the arrangements that are devised here suit different circumstances. And that's one of the reasons why we're saying there isn't a single contracting model that is the right answer. We have developed here not definitive national policy that says this is the only way of doing it, but 3 options that are emerging from our intense engagement with local systems, including the conversations that are happening between the MCP and the GPs in Whitstable, in Dudley, in Greater Manchester, in Wakefield. And so I hope we've got a set of attractive, flexible options, and we will see whether it does the job for GPs as part of the wider package that Arvin's described.
Thank you. I have Wendy and David.
Yeah, thank you, Ian. I understand the GP perspective. I wanted to just go back a little bit to the patient perspective, though. It strikes me as a sort of average person on the street. I get bigger, fewer, better integrated practices, why that makes sense. But for me as a typical patient, why am I not losing choice and why am I better off because of this?
So I'd pick up on 2 themes from that. So the first is on your point around patient choice. As MCPs come into being, the MCPs themselves realise that they need to find ways of safeguarding the ability to move from one practice to another practice that will be contained within the MCP, and we're exploring that with the MCPs. And the other thing that we need to do, and that they're also convinced by, is that there's a set of NHS constitution rights for patients to have choice of other services, whether it's mental health services, whether it's elective care, and we'll be working with the MCPs and the PACs to make sure that those constitution rights, as reaffirmed in the forward view, are then systematically delivered for their patients. And for patients with the very highest needs, who might be most dissatisfied with current services, we're coming on later today to the learning disability programme, that they're increasingly offered integrated personal budgets so they can design for themselves the services that they want. And Tower Hamlets is an MCP vanguard that is also one of our integrated personalised commissioning pioneers that's beginning to show how you combine those different services together. The second theme I wanted to pick up on is on continuity of care for patients. So the research over many years shows that patients often like small practices because of the relational continuity. And one of the main things that the MCPs and indeed the GP federations are looking at is how scale can both continue that continuity but provide a better, more joined up service for the people with the highest needs. So actually, if you're an 85-year-old person with multiple comorbidities, you might be able to see your GP, but only for your traditional 10-minute consultation. Whereas if I take you to the Fylde Coast, to the extensivist model there, you might be part of a group of patients that's been identified as needing intensive assessment and support, home visits, the local pharmacist, actually looking at polypharmacy and dealing with you holistically in a way that you just can't do in a 10-minute consultation. So one of the reasons why some of the GPs and indeed geriatricians and pharmacists are really attracted to these models is it can enable them more time to have the more intense continuous relationship with the patients that need it most.
Thank you, Malcolm. I think one thing to say is this: these proposals were given a good workout in the commissioning committee, so and are recommended to the board there. So important to recognise this is not the only point of challenge and governance. I think, Ian, my question is really about implementation. So, you know, if I look at the 10 essential jobs in creating an MCP, you know, you're changing people, process, technology. It's a very fundamental change. And it's a very significant financial change as well in the way the flows work, etc. So, and as you said yourself, the establishment of the MCP is not the issue. The issue is redesigning the care pathways and processes to be able to deliver better support for patients. So, with that in mind, that it's a big change, it's very important, and I suspect given in STPs this is going to be a model that people will want to adopt more broadly. Two questions. One is, how do we support is there enough change capacity and capability both in NHS England and in the system to support delivery? And secondly, you know, there have been some problems in establishing big new innovative ways of working. For example, United Care would be one. How do we avoid some of the mistakes we've made in the past? What assurance can you give the board on those two?
Thank you, David. So, on your first point around is there enough support, I think that becomes a really critical issue when we get beyond the vanguards.
Yeah.
And so we were having the conversation yesterday. I'll be working very closely with Matthew and NHSI around how we can provide joined up support, not just to support the transformation through MCPs, but the delivery of the STPs more widely. And the support we provide for accountable care models is part of that wider support, and we recognise that there is a big job to be done to gear up local systems and indeed NHS England's own regional and local teams working hand in glove with NHSI and other partners, because this isn't just about NHS England and NHSI, it's also about PHE and HGE and NHS Digital critically. On the Uniting Care, thank you for raising that. I think there are 4 ways in which this will be different from Uniting Care. So first is the very design of the programme with the vanguards, that we're starting first with the care model changes rather than thinking this is just a procurement exercise. This is about local leaders that are getting on, driving and creating the actual teams and making the service models work. Secondly, there's the design of the contracts themselves, the population basis, the service scope, the financial flows. We don't have the complexity of just carving out an over 65 cohort. There's a set of things that are being done very differently here compared to that Cambridgeshire contract. Thirdly, there's some detailed, dedicated work that my team have been taking forward with Paul on the assessment of risk and how that financial risk is managed and what mitigations need to be put in place around that. And then fourthly, there will be, for each of the vanguards, as a learning process, a joint oversight between NHS England and NHSI of each of the procurements that will be occurring in the 6 intensive development sites. And we will sign those off nationally, not just locally, and as part of a learning community.
Okay. So I think the change capacity and capability, what I heard you say is sort of that's work in progress. And it's clearly critical, and maybe, Malcolm, that's something in due course the board can return to, because it's absolutely central to our ability to effect changes in a safe and timely way.
I think just building on that, I think one of the distinguishing features of Uniting Care was the vehicle that was used as an LLP. And I noticed in paragraph 16 of your cover paper, you talk about different vehicles. You don't include an LLP. Or do you?
I think sorry, finish your...
No, well, I need...
yes, we absolutely do include the possibility
Okay.
of LLPs, not least because some of the emerging provider forms may come out of, for example, general practice and GP federations. And I think the issue we have is that we don't want to end up creating an inadvertent bias where we say, in order to mitigate the risk, we're pushing you towards a particular form of provider, for example, a statutory NHS provider, when we know, of course, there's lots of risk associated with financial financial management in those forms. I think the bigger question is about to what extent the risk is clear and understood, and there are effective ways of ensuring that it is owned by the provider, including, for example, the issue of parent company guarantees or balance sheet strength. And those are exactly the kind of tests that the joint work that Paul and I are doing will be assessing and looking at.
I think that's very reassuring. I think the second point, and building again on David's question to you, I suppose is the pace at which we crystallise these models. I think this is just so important to get right, and working with the 6 areas is a critical way of developing the 3 potential organisational models and contracts. But alongside this, we see the STPs developing at pace. For me, one of the critical components of the development of STPs will be the MCPs evolving beyond the vanguards and evolving in other areas where presently they're at an early stage. So do you see these 2 work streams converging satisfactorily so as to provide a clear model that can be used within the STP frameworks?
Well, absolutely, I think so. And if I can give you an example about the complementarity between the STPs and the new care models. If you take an area such as Greater Manchester has the wider plan, the STP, for its geography. Within that, it's got a whole different array of implementation mechanisms and methods, including the development of new forms of acute collaboration, for example, Salford and partners, the work that's going on in central Manchester, the work that the Christie is doing with partners in creating basically a cancer scaled model across GM. We've also then separately got the development of the MCP Vanguard in Stockport, and indeed across the whole of GM. Tracy Vell, the local medical committee secretary, has been leading the work to develop 10 local care organisations, which is a GM version of MCPs. And these GMCs as ways of then giving effect to what the STP is looking to try and deliver.
Good, okay, that's very reassuring. I suppose the question is, for me, the holy grail of this is actually the contract, and getting that right, the commissioning and the contract, and getting the crystallisation, working through with the 6 areas that you mentioned in the paper, but on a programme that then allows a greater spread as we move into implementation of the STPs. So I think I can take from what you say a good assurance from that. May I raise further questions for you? No, can we thank you? I mean, and I know you and your team have put an enormous amount of work into this, working closely with the vanguards to come up with quite exciting new models of care. So thank you for that.